Oh, I think we figured it out.
Sweet.
How's it going, dude?
Good man. Just at home with my puppy, watch him tear shit up like he
Nice.
does. Besides that, day off. We do like a Kelly, I think it's called, where we have a 4 day break. And I took
Okay.
a day off on the last day, so I'm on 6 days, which is real nice.
Oh, nice. You got anything fun planned?
Well, this time no. My girl was out of town, so I had to bring the puppy with me to the station. And the first 2 days it was fine, but it kind of got a lot. We're a rather busy service. Not like 20 calls in a day busy, but like we'll easily get 10 over the course of 24. Like bad nights would be
Yeah.
like maybe like 15 in a day.
Okay. It's a lot. It's a lot for one day.
It's good experience though.
Yeah, for sure. Yeah, when I first started, I was working on a private service right outside of Pittsburgh, and we ran a lot as well. It seems nuts now to think about it, because for us, like, 3 flights in a day is a lot, but we used to do like 10 runs, no problem. And
Yeah.
that was just how it was.
Yeah, but think of the pressure on you though with just a single flight.
Yeah, it just definitely takes a lot longer with like charting, and it's a lot of
Mm-hmm.
yeah, a lot of time, whereas our runs are pretty short.
Do you guys like if you land and like a patient needs intubated, will you intubate them where they are and then like pretty much have them ready to go by the time you're ready to fly?
Yeah, we try and do everything on the ground. At
Mm-hmm.
least where I work. Every now and again, we'll get in a situation where we're trying to manage the airway like en route, but we definitely
Yeah.
prefer to do it on the ground, especially because most of the bases in this region are pretty small helicopters. We fly in A-stars, so there's not a lot of room to
Mm-hmm.
do stuff once you get up in the air.
Yeah. Seems sketchy, man.
That's not that bad.
You like flying in general?
I do. Yep. I've tried to leave a couple of times, but I keep coming back.
Well, that's good, man. You found your niche.
Yeah, I think so. But yeah, I didn't know if you want to just dive into your notes you sent over, and we can just kind of run down that checklist like we did before.
And everything I had on here, even if it doesn't have a question mark, most of it is kind of like um, I know a lot of them are just questions in like their context. But so like the first one, the albuterol for hyperkalemia, I don't like our protocols. We don't have this in there, but I had a doctor that I respect a lot. He told me that you can use albuterol to get serum potassium into the actual cell itself. And so I was thinking on it, and what do you kind of like? Because with hyperkalemia, the big worry that we have is the bradycardia, and of course, it going into like a terminal sine wave or something. But have you ever seen it done? Have you ever used it? Kind of, what are your thoughts on it?
Yeah, the only time like we do use albuterol for like a hyperkalemia protocol. I don't know if I've ever done it in the field, but we do that sometimes in the hospital if we have someone
Mm-hmm.
who is hyperkalemic, and there's decent evidence that it works. But it's like part of an overall strategy. So we're not just doing that. We're doing like a whole sequence of things to both shift the potassium back into the cells and also to get rid of some of the potassium. So yeah, it's like one of the components in that. The only time you really see it mentioned in the pre-hospital setting is with crush injury. Um,
Yes.
yeah, so if you had somebody who was like stuck under whatever for a long period of time, um, ideally you would, have access to everything. So if it was an extremity, you could, you know, put a tourniquet on the extremity. When the
Mm-hmm.
when the object gets released, we're worried about the influx of all that like tissue and the contents of the tissue that broke down getting back into circulation. Um, Ideally, the tourniquet would solve that problem, but if you still had some of that stuff get into the body, you have two primary concerns. One is like going into acute renal failure, because you have that myoglobin release in the bloodstream, and the other is the hyperkalemia with the potassium influx. So specific to the hyperpotassium, I'm sorry, the hyperkalemia, the high potassium, um, that our normal like treatment in a hospital setting, we would do the albuterol. If we're concerned about any arrhythmia, then we would give calcium to stabilize um, the cardiac tissue itself. And then we also will give insulin and dextrose. So giving insulin will shift the potassium into the cells in a similar manner to the way albuterol works. But then you're at risk for the patient becoming hypoglycemic. So then we give dextrose as well.
Mm-hmm.
And then to get rid of, like to get the potassium actually out of the body, not just to cause a shift, then we give K-exolate. But in the field, like we don't really have those options. So you're basically limited to like in the context of a crush injury, you can do the tourniquet thing. And then you can do albuterol. Like most of us aren't using, most of us don't have insulin in the field. So our options are limited in the field. So that's when you might see it.
Yeah, I saw with the insulin, like obviously we don't have it, right? We're just a standard like fire service. But I was reading, and I believe it was the calcium channel blocker and beta blocker, MCRIT, or maybe it's like the Internet Book of Critical Care, but they had insulin as well, and they were saying do the same thing, because when you give the insulin, you got to worry about the hyperkalemia, and then give that, and then you're just kind of balancing the two amongst one another.
Yeah. Yeah. And like, I don't know of any programs that like carry insulin in the field. That's mostly a hospital thing, but yeah, that's definitely the idea behind it. That said, I don't know about using it as like an agent specifically for bradycardia. I think if you were worried about a patient
Yes.
going into a lethal arrhythmia with high potassium, like calcium will be your fix for that. Maybe not your fix, but it'll prevent that lethal arrhythmia, hopefully.
Sweet. That one's covered. The second one, so like this is going more with the hyperkalemia. So if you have your patients that, and the only hyperkalemic patient I've ever had was pretty severe bradycardia, and we picked them up from their house. They had skipped however many days. But if you have that patient that's kind of on the in between, they're not very bradycardic, but maybe they have like their hyperacute T waves. Would you leave them alone if they're asymptomatic, or would you give them that calcium because you know that they're going to end up needing it anyway?
Yeah, so if I'm worried about them going into a lethal arrhythmia, I will give the calcium. Generally in a hospital setting, or if you're working with a program that like can draw labs in the field, we base that on a serum potassium, but like most of us don't have that. So if I'm worried about it, like if I'm like, man, this guy does not look good, and I'm worried that they're going to deteriorate, then yeah, it's totally okay to go ahead and give that calcium.
Sweet. And then I noticed we have sodium bicarb in our protocols for the hyperkalemia. I would assume this is because whoever's writing the protocols assuming that they have renal disease, and then therefore they have metabolic acidosis, or does the sodium bicarb help directly with the hyperkalemia?
So the sodium bicarb doesn't help directly with the hyperkalemia, but if you start to fix the metabolic acidosis, then you will get a shift of potassium back into the cells. So when you're in a state of acidosis, your cells lose potassium into the bloodstream. So that's when you see the elevated potassium, and you're at risk for having that arrhythmia. So whatever you can do to either directly move that potassium back in the cells or fix the acidosis, like will address the problem.
Okay.
You don't often see, you mentioned that like you never see sodium bicarbonate in a DKA protocol.
Mm-hmm.
There's not a lot of great evidence about like sodium bicarb in general for metabolic acidosis. If you, yeah, I mean, you still see it given like fairly often, like kind of as like last ditch effort, be like, oh man, my patient's super sick. I don't really know what to do. So let's give bicarb. If you are going to do that, the preferred method would be to do it like a slow drip versus like slamming it. Because if you slam it, it either has no effect or could potentially make things worse. But I don't think I was trying to find an article. Let me see if I still have it pulled up about this specifically. Bicarb in DKA. I know that we like almost never see it, but I wasn't sure if there was like specific stuff on it. And I did come across something. Let me see if I can pull it up here. Yeah, there was an article. I'll send you a link that was just in general about bicarbonate in patients with metabolic acidosis in general. So it kind of like goes through just the overview of everything, but it also talks about like specific etiologies, whether it's like lactic acidosis, septic shock, DKA, and it specifically talks about DKA and that there's the evidence just isn't there to support its use. So, but I'll send you a link to that and whatever else we come up with on the way.
In your opinion, do you feel like sodium bicarb is kind of something that EMS is really hanging on to? Because it seems like it's been around a while, and everybody knows now you can't push it in codes and expect it to work at all.
Yeah, and it's not just in EMS. Like you see it in the hospital too. Like, I mean, we always the cliche example is like, all right, you're working a code and you get like 4 or 5 rounds in, and then you're like, all right, what are we missing? I don't know, let's give bicarb, right? And you see that in the hospital too. It's not specific to EMS. Um, I think eventually that'll fall out of favor. But there's like a lot of like folks tend to hold on to something that like gives them a chance of hope. Like in that situation, like you're pretty much out of options. So like, well, it's probably not going to hurt. It's definitely not going to
Yeah.
fix anything, but it's probably not going to hurt. And the theory behind it is that, like it can fix in if you give it correctly, like it can help. It's like one tool in your tool bag to like fix acidosis. So that's kind of the idea behind it. But the way we give it as a push dose in cardiac arrest is just not effective.
Yeah.
So I think eventually we'll see people stop doing that. But for now, yeah, for now it's there.
You like it for like asthma or aspirin overdoses? I had a lady that tried to kill herself. She took an ungodly amount, like a Sam's Club bottle worth of aspirin, and they ended up putting her on a drip in the ICU.
Yeah, we'll see that sometimes with overdoses where we'll like have them on a bicarb drip, like like slow and steady for quite a long period of time in cases like that. And in that situation, totally makes sense. Um, yeah, I think most often I see it in the hospital with overdoses, like when you have poison control giving you specific guidance on the case.
Okay. Sweet. I think that covers all the hyper K ones. So number 3, the calcium for the PEA. I was listening to, I think it's 257 on MCRIT, and it's a episode specifically about PEA and kind of talking how it's there should be like a deviation and like, is there contractions that's not generating a pulse because it's not strong enough, or is this a true PEA with no cardiac contractions? Now I know in the field we don't have echoes, at least we don't, so there's
Right.
no way we're down the heart and see if there is a contraction in the first place. But like let's say you have your tube, your compressions are going well, right? You're kind of hitting that point that we just talked about where people are like, okay, what are we missing? I know they say push it for any dialysis patients because you should assume hyper K is the thing that kind of took them down, but I couldn't find any really bad adverse effects
Yeah,
of pushing calcium in the case of a PEA.
yeah, there was actually a podcast just recently. It's called EM Cases, and it was
Mm-hmm.
episode 169. It's like the most recent one I listened to, but they were just reviewing, like they were doing an update on like changes in practice for cardiac arrest in general, and they specifically talked about calcium, and they kind of had the same idea, is that um, if you can't make that distinction, like it may be the case that it's just a contraction that is not strong enough to perfuse, and in that situation, like giving calcium might make sense. Most of that data collection is like in the hospital setting where you have access to echoes, so you could like make that determination pretty easy, or bedside ultrasound. In our situation in the field, I think that makes sense. Like if you had a PA arrest and you weren't sure, yeah, I mean it's not going to hurt. The data is not there, but again, the data is skewed because it's assuming you have these other like assessment parameters that we don't have in the field. So I'm with you. I'm with you on that one. I think there is a case to be made for giving calcium in a PEA arrest when nothing else is working.
Yeah, because I'm like, well, you want to stay away from like being cookie cutter, right? Like I heard back in the day they had like a unconscious cocktail where they would, push dextrose and Arcan and like thiamine, but it just seems like it makes sense because I mean we honestly don't have the tool to determine it, and if there's no hardcore side effects.
Yeah, for sure. Yeah, I think in general, the EMS field is getting away from just like dumping the drug box into somebody. There's still a few holdovers like the sodium bicarb thing. But in this particular case with the calcium for PA, like I think there's likely a use case there. There's not a lot of data collection on it. You'll sometimes hear calcium referred to as like the poor man's pressor,
Hmm.
because it, you will get a little bit of extra squeeze from the heart after giving it if their calcium was low. So I think that's reasonable.
Sweet. I mean, I don't really expect calcium to turn around because, like, how many rounds of epi in are you going to be before you're even getting
Right,
calcium? You know.
for sure.
So good on that one. So the fourth one's kind of a two-parter. When you were, you kind of answered it involuntarily. I didn't even know I was really mentioning it earlier when I talked about, are you tubing, like in your case, are you tubing before you go? You said you would. I have always tried to tube in the house to get that knocked off the list and just get that airway
Mhm.
like solidified. But I've never had a case of it. But I just figured the more you move, the more chance that tube's going to come out. And you can imagine how a bunch of firefighters would be moving a patient, as they're frantic. And
Right. Yeah, I mean, I think it depends on what the situation is. So, like, if you find yourself in a situation where you have to intubate somebody for like airway or respiratory problem, um, it makes sense to do it as long as you brought all your stuff into the patient's home or the scene or wherever. Don't leave your shit in the truck. It doesn't do you any good. But as long as you have your
mm-hmm,
stuff there, make that scene as controlled as you can and do the procedure. Now, if it's like a traumatic injury where you need to get that patient to an OR, like it might make sense to use like a supraglottic airway or just throw an OPA and bag them and like get moving fast.
mm-hmm,
So I guess that's the initial determination. Like if the patient like needs to be in the hospital for whatever's going on, then do it on the way or use like an alternative. But if you can fix the problem, like if you can address it, then
mm-hmm.
then I would recommend taking the time to do it there where you are. In the case of cardiac arrest, um, I always tended when I was like working on a truck, tended to like work the code where I found them,
Yes.
because you're not going to do good CPR on the move. Um, when I was on the trucks, like we intubated all of our codes, like that was just what we did. I think now there are programs that are more open to the idea of using supraglottics or bagging or using other strategies, and I think that makes sense. There's definitely a lot of like um, cultural pushback on that idea. Like medics don't want to lose the um,
And babe.
yeah, they don't want to lose the ability to innovate, and they don't get to do it that often. So I can
Mm-hmm.
see that too. Like I was the same way when I was working on the truck. So um, yeah, I guess the simple answer to your question is it depends why the patient needs to get to the hospital. If the hospital is the only thing that can fix them, then just do it on the way. But if you can fix the problem where you find them, then take the time to do it where they are.
Okay.
Yeah. And then once you have the problem fixed, like, if it was like a airway ventilation problem and you fixed it by intubating them, just take your time moving them. Like you fix the emergency and it
Mm-hmm.
like nobody care. Well, maybe you have supervisors that care, but in the grand scheme of things, nobody cares if it takes you 20 minutes to get them from where you find them to the
Yeah.
truck, as long as you're doing it safely. Um, so that's kind of where I stand on that one.
Yeah. I like it. And then I put that link. So on our codes, they have us put them on a OPA and a non-rebreather until we have like the Lucas set up, until pretty much the first initial hassle is kind of out the way. And then they
Right.
always say tube after the round, but generally, I mean, we put a medic and an engine on every single call almost. So that's 6 people on a call, so I usually don't get 2 rounds in before I'm intubating. Like I'm usually like 1 round in, and then we're gonna go and intubate because there's just so many people. Everybody kind of knows what to do, so it gets done very quickly.
Right.
I didn't know, like I'm still gonna have to do it right because it's the protocols of our place. But what do you think on the of like kind of passive ventilation, kind of like when it's letting off the chest, it's drawing that air in, and
Yeah.
then like obviously tube, right? But
Yeah. I know there was like a decent amount of like investigation into this idea like a while back. And there were some programs that were just working codes without managing the airway. They would just put a non-rebreather on their face and then do compressions only. I don't think that the data ever like supported it, or if it did, it wasn't superior to, managing the airway. That said, I think like probably objectively, I haven't like dug into the data on this because I don't like where I work, we don't routinely like run codes like you do in a 911 service on the ground. But I think probably the best bet would be just to put in a supraglottic airway because it's so fast. And then you for sure make sure you ensure that you can ventilate effectively and oxygenate, but you also can keep doing compressions. Like there's maybe a use case that like the passive oxygenation isn't quite as effective, like just the chest recoil and compression isn't drawing enough air. And then there's on the other end, there's an argument that doing an intubation just takes up too much time. It takes hands off the chest. So I think like probably if you dug into the data, like the best case would be just to use a supraglottic. But again, there's going to be a lot of resistance to that, both like out of hospital and in hospital. But yeah, I would have to look up and see like what the current state of evidence is on that idea. I haven't seen anything about it in a while.
Four. Oh, can you hear me?
Oops. Yeah, you still there?
Sweet. Yeah.
I don't know what was going on my computer.
Sweet. So 4's done. 5. Let's see. So in our protocols, they say you can give adenosine to somebody who's if they're younger, like if it looks like an SVT population, but they're showing wide. Now, obviously not like true VTAC, like coded, but they're stable, they're tachycardic, and it's wide. And I get the thought process behind it, right? Because it might stop it, might slow it down, and then you can kind of see if there is something in there. But isn't it really dangerous? Like, let's take WPW, for example. You have that Kent bundle. If you block the AV node, won't you have pretty disastrous results? Because now your Kent bundle is making up for 100% of the impulse coming.
Yeah, so you're right on track. If you have someone with WPW and they're like in a supraventricular tachycardia and you give them adenosine, you could put them into VTAC or VFib. I would have to check and see like what the actual like incidence of that is. That I'm not sure. I know it's quite rare. But yeah, that's definitely a concern. So if you had someone that you like knew had a history of WPW, like if somebody told you, then I would be like hesitant to use adenosine.
Okay.
But just routinely, I wouldn't just never give adenosine because I'm worried about putting somebody into VTAC or VFib. And the fix to that would be just to like make sure you have pads on the patient so that if you do put them into VTAC or VFib, then you can just shock them out of it. But yeah, so a simple answer would be like if you have a confirmed history of WPW, maybe hold off on the adenosine. If you are giving someone adenosine in general, just make sure you're ready to like cardiovert them or defibrillate afterwards, just in case. There was, yeah, go ahead. I was going to say there were two references worth looking up. One is there's a Life in the Fast Lane article that just came out like a month or two ago about distinguishing different wide complex tachycardias. Is focused on like VTAC and SVT. So I can send you a link to that. But that was like an interesting read in general. And then there's another one from a few years back by a page called Canadian, and they specifically talk about this case. Like they talk through how they would manage a patient. She's I think a younger female in SVT. The crew gets ready to give adenosine, and then the patient mentions like, "Hey, I actually was told once that I have this thing called WPW. What's that all about?" And it just like talks through their like how they would manage that, and they basically come to the same conclusion that like I don't actually remember like specifically what they said in the end, but through their discussion, they talk about like if you're going to give adenosine to a patient like this, just make sure you're ready to make sure you have electricity on hand and pads on the patient's chest so you can get them out of any kind of dysrhythmia you put them into. Um, but in general, like you could likely wait, right? So we're giving um, like if we're following ACLS, we're giving adenosine for a symptomatic but stable tachycardia. So you could use your clinical judgment and be like, you know what, like I'm okay to like to hold off for now and see how the patient does. Also depends on your system. Like if you're close to the hospital, that's one thing. If you're going to be like if you're out here in New Mexico and you're 45 minutes away, it might be a different story. But you can also wait. Like you don't have to decide right away. I know we like teach ACLS like every fork in that algorithm is like an instantaneous decision, but you can sit on things for some time, especially in that situation where your patient is stable.
Sweet. We're knocking these out. 5 is done. So with 6, I asked about early repolarization. That EKG website by like Dr. Kasha, one of the Mayo Clinic guys, he has a quick little like 10-minute video on it. He was saying it's linked to sudden cardiac death. Now he says it's very like obscure and it's not something that was like highly researched, but just something to be aware of. We got called to a jail and we get there and it's like your typical, oh, I'm having chest pain or I'm having trouble breathing. But he's like, and he's a younger male, you know, he's like my age, but he's saying things that are like, and like, how do you know to say that? You know, like he's saying, oh, it wakes me up from my sleep, and oh, it's crushing chest pain, and oh, it galls like goes to my back, and like I'll start sweating randomly, and he's just kind of like very like textbook, you know. And of course, the population, like they're probably going to give you more BS than a normal population because their freedom is gone, right? But how would you just kind of put him in the group of everybody else? Because we did a 12 lead on him. He had early repolarization, and he was like V1 through 3. He was elevated, no reciprocal changes, like not really nothing else saying STEMI by any means. And of course, he didn't have a STEMI. They discharged him later. But does it kind of snag on your brain when you see that early repolarization? Does it make you think of anything? Or are you just kind of like, oh, yeah, early repolarization?
I guess I just make a mental note of it. Like I don't think in that situation that you're describing, I would be like extremely worried. Like I wouldn't be, you know, calling like for medical consult or putting pads on the patient's chest or anything like that. Um, yeah, that's another thing that I would have to like look and see what the like specific incidence of like sudden cardiac death related to early repolarization and you know in the general population that has it is. Um, I imagine it's quite rare, so I wouldn't be super worried about it. Um, but it's always something to keep in mind, I guess.
Sweet. 6 is done. So I took this airway rodeo class by Life Flight. It's just kind of like a flight medic group.
Mhm.
Have them out there, but it sounds kind of like pretty much what you do. Like they're flight medics, and you know they go around teaching. And they gave us this. They were talking about lidocaine, using it for head traumas to reduce the ICP.
Right.
In a previous book that I had on MCRIT, it's like one of his recommended readings. I bought this book and they talked about the same thing in one of the airway chapters. So I was wondering, like, would you use it in a? I understand pre-treatment drugs take like 2 to 5 minutes, and I feel like in situations where I would be intubating, you're not going to wait 2 to 5 minutes because we don't have RSI, we don't have DSI, we don't really have any of that.
Right. So I don't think most people are doing it anymore. That for sure was like standard practice for a while, or anytime we were doing a RSI, we were worried about traumatic brain injury or head injury, we would pre-treat with lidocaine. But that I don't know of any like flight programs, at least in this area, that are still doing that. But there are still a lot of references that discuss that, and I imagine it might be different. You know, like everything is changes a little bit by depending on where you are in the country. So there may be some spots that are still doing it. Um, but yeah, we don't routinely give lidocaine when we're RSIing somebody with a head injury. But at one time we would have. And yeah, and here, like I don't think I think even when I started flying here, this is in 2013. I think even then it was like already off our protocols, or maybe it was like shortly thereafter. So it's been a while that we're not doing it. Like some are
Okay.
in the vicinity of like maybe 10 years or so. But like with anything in medicine, like things take a long time to change.
Yeah.
And there was like, I think there at one time there was some decent evidence that it did reduce a spike in ICP if you pre-treat it with lidocaine. So, and like the trade-off is negligible, like you're not going to hurt the patient likely. So it seems okay. But it's one of those things we're generally trying to get away from just doing all the interventions and trying to focus on the ones that have like demonstrable value and focus on doing those ones well.
Sweet. Lido's done. So 8, the magnesium dose timing, because it seems like, I know for airway, this is not going to be one of your like main attacks really at all. It's like a third or fourth line. But for torsades and the preeclamptic seizures, this is like torsades are probably going to be running a code, because I haven't heard of anybody with torsades who's, not dead. But in these instances where magnesium is really like the kind of fixer of it, how quickly are you giving it? Is it 2 minutes? Is it like over 5 minutes? Because I know you never slam magnesium, like you always have to dilute it, correct?
Yeah. I don't know if I've ever seen a protocol that like advocated for giving magnesium as a push dose. Um, Other than if you have like a non-perfusing polymorphic VTAC, then you can
Okay.
give that one as a push dose. But generally you would dilute it over like 5 to 10 minutes.
Okay.
And in some situations you do it longer. So um, like for like a real bad bronchospasm for asthma attack, if you're all the way down your algorithm and giving magnesium, you could give that over like 15 to 20 minutes. Um, this is something I probably should know like off the top of my head what the exact timeline is on all the indications of my magnesium, but I just looked that up when I need to give it because it's not like my first line. So
Yeah.
I fully
Well,
support. You can always look things up.
yeah. Well, and how often is it? It's like, your average medic give you magnesium. I feel like it's kind of a niche drug.
Yeah, I don't know if I've ever given it pre-hospitally.
Mhm.
Maybe. I mean, we give it in the hospital to like replace labs all the time, but that's totally different. But I don't know if I've ever given it in an emergent situation. Um, I maybe have given it like an asthma patient like once or twice. Um, I don't know. I guess back when I thought doing all the things all the way down to the bottom of the algorithm like made you cooler. Um, but yeah, I haven't done that in a very, very long time. I like your hoodie, by the way.
Thanks, dude. My girl. So I initially, right, and I bought a size too small. I was like in my phase of like I need to go to an XL, so I bought a just a normal large.
Yeah.
And as soon as I get it, I'm like, shit, I am an XL. And they bought me this one in an XL, and it's super nice, dude.
Nice. I don't have a
Sometimes,
hoodie. I don't have a hoodie yet. I might have to get one eventually.
yeah, you're gonna have to, dude. At nights, like if we don't take out like our officers or something, you know how uniforms kind of like they kind of get flexible as the night goes on.
For
I'll
sure.
wear chilly or like raining or something, because the ones they gave us for work are real thin, and you'll be going down hard if you wear it.
It's a solid option. I like it.
So ketamine. So for us, we have the quarter of a milligram per kilo over 10 minutes. I've
Mhm.
never given it. Anytime we've ever had pain, I pretty much stick with fentanyl for everything. Um, is that like, what are your thoughts on that dose over that amount of time? Does it work for pain?
Um, so it depends. Like where I work, our dose for pain is like zero point 0.1 to 0.25 mgs per kilo. And we
Mm-hmm.
always joke that it's like a homeopathic dose.
Yeah.
Um, but that said, like I have seen it work, and it varies a lot by the individual. Um, so specifically with ketamine, like a lot of our medications are, we're gonna like go down a rabbit hole here, but a lot of the medications that we use in general they're metabolized in the liver by your cytokine P450 system. Um, and then in that system, there are specific subtypes that like affect like how you metabolize drugs. Ketamine specific is metabolized by like multiple um, different components in that system. And then each of those different components like may or may not be an active metabolite, depending on like where you're looking in the literature. So specific for ketamine, there's like a lot of variation in like how an individual responds, because it's not just like one direct pathway. Like this drug like gets taken up in active form and gets metabolized into an inactive form via this distinct route. In ketamine, it's like a little bit all over the place. So there's like a couple different ways it gets metabolized in that overall system. And then sometimes those different metabolites are active as well. So basically that's like a long way to say that like ketamine is quite complicated and that like some people will respond to a super low dose just based on like how their physiology functions. And other people, like you'll give them that 0.25 per kilo and you won't really notice anything. But it's highly variable. Um, the good thing about ketamine though is like you can always give more and like repeat it. And there's not really like a upper limit. Like you might put a patient into like a dissociative state, but like at that point, giving them more will just like cause it to last longer. It's not
Yes.
like so like in that sense, it's like a very safe medication. Um, that is definitely like not everyone ascribes to that idea, but like for me, if I'm not sure if it's like I err on the side of giving more ketamine than less within the
Okay.
restraints of my like of my protocol. So I'll give that upper end for pain. I'll give 0.25, and then I can give it as often as every 10 minutes. So I'll just like keep repeating it. And
Okay.
I also like if it's for a patient who's like we use it a lot for post intubation sedation, and
Mhm.
I have a different higher dose for sedation, so I can always just use a higher dose, and it covers both pain and sedation.
Yeah.
So
For
yeah,
ours, we use the 1 milligram per kilo anytime that we intubate somebody. They just
mhm.
tell us to push it on, unless it's like a prolonged downtime or something like that. It's where they would be
Yeah,
pretty.
no,
Um, and I have given it for that. I really like it for that. I mean, I've never had a patient like come to after being intubated, but the only times I've ever intubated somebody are codes. And kind of the area where we get our codes from is we have an area of the city, like it's pretty bustling. It's like 40,000 people, but then so much of the population lives in the sticks, to where you'll be like 50 to an hour away from Kansas City in some of the parts of the city.
yeah, and in that case, like using ketamine at a higher dose for sedation is like it's super good for while you're in transport, like after you do your emergent interventions, just keeping the patient sedated and calm while you're making your way to wherever you're going.
Sweet. That is 9. 10 is a bit more of a discussion. I'm sure I'll have a question derived from it. We have this patient and we get there and he just looks like he's going to code. I mean, sweating, pale, clammy, like telling you he's going to die. He's like half the time talking to you, half the time like reaching in the sky. He looked terrible. And his vitals were pretty unremarkable, except I remember his blood pressure went from 170 on the toilet to when we were like 10 minutes out, he was like 90 systolic. And the whole time, I put the pads on him and everything. After a 12 lead, he had a history of MIs, history of PEs. Like, I mean, he had it all. And so I asked for a report back from the hospital when they got done, and they sent it to our EMS chief. And they said that this guy was diagnosed with severe dehydration and an acute kidney injury. I was shocked by it. I mean, I thought for sure, like, I was thinking like PE or something that was like a hardcore hemodynamic hit that he was going down. But then I kind of started realizing he was outside for, like an hour. And so maybe that's where the sweating came from. Except he told us he had been inside for like 20 minutes. It was like my first patient of like, what the hell's going on? And then finding out had nothing aligned with like what I was going down.
Yeah, I guess I have a couple thoughts on that. One is that like there could have been more going on than just dehydration and acute kidney injury, but like a diagnosis of AKI or acute kidney injury is like an objective diagnosis based on lab work in the hospital. So
Oh,
sometimes that is like when you're not sure what's going on, you're like, oh, they have an AKI. Um, I'm trying to think of like another example of something like that. Um, I don't know. I can't think of another one off the top of my head. But it could very well be that like that was like the most obvious thing based on like objective measurable parameters. But that doesn't necessarily mean that like your suspicion that something else is going on is invalid. Like being being down on fluids, being super dehydrated is dangerous in and of itself, especially with someone who has like a significant cardiac history. Um, but that may not be like a diagnosable thing. In that situation, like you would expect that he would have, I don't know, like you might see some evidence of like cardiac stress, like elevated troponin or EKG changes. But that's not always the case. Um, so yeah, I wouldn't discount like your concern that there was something serious going on. Um, but at the same time, like that kidney injury diagnosis is a simple, straightforward thing. So
okay.
sometimes we tend to gravitate towards that. Like same thing if you have like a really really sick patient and you like you have like an outlying lab value that you tend to focus on. So like this patient is septic because their lactate's elevated. And that's not a great example. Um, I don't know. I'll work on that to see if I can think of another comparable example. Um, but yeah, I wouldn't discount your concern that something like potentially very bad could have happened,
Yeah.
just based on that. Um, but yeah, I mean, also the kidneys are quite important. So like, if you, I mean, people can die from acute kidney injury. Like it can set into motion a chain of reactions that um, can be quite catastrophic. So um, most of the time when we're seeing a kidney injury, it's something that aligns with this narrative, like oh he was dehydrated, and maybe he took some NSAIDs or something, and like now his kidneys are hurt, and you give him some time and some fluids, and he recovers. But it can be quite severe. So
Can your kidney patients have a problem um, regulating their blood pressure because of the renin-angiotensin system?
yeah, for sure. Mhm.
Is that more of a something you should expect? Is that kind of a later?
Yeah, that would be more of a chronic finding.
Okay.
But yeah, like if you have somebody who's got like chronic kidney disease or like chronic renal failure, you can, I mean, pretty much every system in your body is eventually going to be affected. Um, so you can, yeah, like you have issues maintaining your volume, your fluid status. You can have anemias related to chronic kidney disease. Um, there's actually, I have to see if I can remember this one right. There's cases of people having anemias that lead to ischemic events because, and then like the root cause goes back to chronic kidney disease. Um, so yeah, like I don't know if that answered your question or not.
Oh yeah, no, real well. 1 second. All right, 11. I've got and I don't remember if I asked this last time. I've got our notes from
Yeah, and
before.
I had this one written down as well. We were talking about like when we normally teach STEMI, if we're looking at ST changes, we identify like the specific part of the heart that's affected based on those changes.
Mhm.
And you had asked about if there are specific injury patterns like within Scarbosa criteria. Um, and I assume that's what this is related to, but I still don't have an answer for that. But it
That-
seems like you found something.
So I was just like wondering on. I mean, it's not like for me, I'm gonna do anything different, right? Like if a patient is having a STEMI and they don't look great, like they're still getting pads. I still need a line. I'm still preparing for them to code. I guess it's more out of you know curiosity, but I would I would just wonder, and even if maybe not even the specific area, like if it can't be localized, but I wonder if when they do have when they're fitting this Carboza criteria is the mortality comparative to just your regular STEMIs. I wonder if it's worse.
Oh, I see what you're saying. Hmm. Yeah, that I don't know. I mentioned that that EKG blog, Dr. Smith's EKG blog. I wonder, I'll have to look and see if he's got anything on that specifically. Because with any of these scoring tools, there's like any of the scoring tools, there's some variability in like patients may tend to have like they may still fit in the framework of this tool, like they may be positive, but like there's some over here on the left and some over here on the right. Maybe these like ones over here in this camp might have ischemia on like, I don't know, the left side of the heart, and these ones have like an anterior wall ischemia. But that, yeah, I don't know. Maybe I should dig into that a bit more and see if I can turn anything up. I imagine the data is there, but this is also like a fairly like in the realm of medicine, like it's a fairly new tool, so
Mhm.
it will likely be quite some time until they get all the nuances figured out.
Yeah.
Um,
And I've noticed some people have like modified versions of the Scarboza, and like Life in the Fast Lane has one on its page on the
yeah,
modified. And I always just use the original one. I mean, I haven't heard anybody speak negatively of it, you know.
yeah. I mean, I think I use the modified one just because it's newer, and I assume that that makes it better, but because I could dig a little more into details of that.
Yeah.
But I think if you're making an effort to just look at Scarbosa criteria in general, like if you have a patient with chest pain, you see a bundle branch block, and you like either have it memorized or pulling out a reference to check it, like that's that's already like above and beyond the average that most folks are doing in the field. Um, so yeah, kudos to you for doing that.
Yeah, because I would hate to have a left bundle and my medic isn't, you know, like he's like, oh, he's got a left bundle, and then just throws it to the side. You're like, oh, what the hell?
Yeah. And I mean, realistically, like a lot of times when I'm doing this, I do it on the way. Like it's not going to change my interventions initially, but it's more for curiosity's sake, or like before I call a report, I'm like, all right, cool. I know I had a left bundle. This guy is like complaining of whatever cardiac symptoms. I'll just get out, you know, like I have it, like I have a little reference card I keep in my flight suit, and I also like can look it up on my, I have like a little PDF saved on my phone with all these references, and I'll just pull it up and, you know, just take a quick look. But I've never actually like confirmed an occlusion using the Scarbos in the field. Um, but maybe someday. It'd be a good nerd moment.
Oh yeah, a fan like once in a lifetime, especially when you get to show up and the cardiologist is waiting on you right away.
Yeah,
And you
dude.
just brain it up with them.
Gold star for sure.
It'll probably happen to either of us, and some medic out there will do it. Not even much. Like it wasn't even that cool.
Yeah, probably.
So 12, I think I had seen something on somebody's Instagram, or I forgot where I saw it, but the question kind of came to my mind, and then I found a journal on it talking about how giving dextrose to a code just because we're just assuming is really bad practice and really bad for the brain. And I think it may have been somebody on Instagram posted saying that you can't trust capillary um, like sticks, like you can't trust a measurement on it, and that you need a venous one during a code. And then I think it kind of branched into that, or maybe I just looked into it.
Yeah, so the I guess going back to like where this pushing dextrose in codes comes from is it's like listed in one of the H's and T's that everyone gets taught. Um, but the problem with that is like this article that you sent discussed is that like if you're hyperglycemic post ROS, then that like tends towards more negative outcomes neurologically. Um, so yeah, that that totally jives. As far as like using a capillary blood sugar on a patient in code, like I guess if your perfusion is not adequate, like if you're not moving that blood, that value is not going to be accurate. So I guess that checks out as well. I think in general, I don't know if we talked about this. I know I've had this discussion with other folks. Like I think having I think having like hypoglycemia on a list of H's and T's like predisposes us to this problem. Like
Mm-hmm.
like the state of being like hypoglycemic is probably not what's going to cause you to go into a cardiac arrest. Like I'm not
Yes.
I'm not saying that like if your blood sugar gets to zero, obviously that's a problem. But it's likely that you know, like if you're down in like the 20s and 30s, yeah, that's low of normal, but that's not causing you to die. What's causing you to die is that you aspirated and you choked and you stopped breathing, like things like that. Um, so I've kind of like over the years, like de-emphasize this idea when I'm in a teaching setting of focusing on like H's and T's, just like without considering each one individually, because I think it does predispose you to problems. Um, in our setting, like in the field, like we don't have access to drawing venous labs almost always in the pre-hospital setting. So I guess if you got a reading like early on in a code, like before you did, like right as you started doing high quality CPR, like you got on the chest and somebody else was like, oh, I'm gonna check a blood sugar because you have 10 people on scene. Maybe before you act on it, just wait and like once you start perfusing for that patient doing compressions, like maybe check it later in the code.
Okay.
Um, I don't know if that like I don't know if that totally makes sense. Like I don't know if there's any data to support that. Um, but I don't know.
Rationally, it makes sense though, you
Yeah.
know?
But I wouldn't focus on like a hypoglycemic state. Like all those H's and T's, even if you want to like consider them blindly, like they all come later on after we
Mm,
do the initial like high quality CPR and like stabilize things. Other than like obvious things, like you know, if you had a bleed or like an obvious injury that caused a pneumo or something like that.
yeah.
Um, but yeah, I think it's totally okay to de-emphasize hypoglycemia in managing cardiac arrest until later.
Hmm.
Yeah.
Yeah, I
Um,
would agree. And we have these the IVs that we have, like the thing that holds the needle for us. It's got like a little spot you could put like just a normal pin, and you
oh yeah,
just
that's a fair point.
push down on it. But still, it seems to make more sense to do it during compressions though than it. And also, pretty
Yeah, for
much every
sure.
during compressions anyway, because we should be on the chest an insane amount.
Yeah, this shows how long I've been like off an ambulance because we like never have to do that anymore where you like start your line and then you like check a blood sugar with the blood from the IV. But that
Yeah.
totally makes sense. So I guess like if you wanted to do this, like, I don't know, if we're trying to come up with like a good, better, best strategy, like maybe somewhere in the middle would be like start another line like
Mm-hmm.
later on in the code. And then from that one, check your blood sugar. That,
Okay.
yeah, maybe that would be like a good middle ground.
Yeah.
Yeah.
So 13. Let's see. So 13, I'm pretty much asking about cardioversion and pacing. And they like when you do ACLS, they tell you like, altered mental status or chest pain or respiratory problems or these things fit in the like unstable category of it, right?
Right.
Would you mostly, besides like the map or the blood pressure, I mean, obviously if that's like critically low, like 70s, 60s, like okay, we're not giving meds, like we need to shock them now. Kind of besides that, would you kind of dictate it on each patient, like
Yeah. I mean, if you have like somebody who, I don't know, like they tend to have chest pain, like they're diagnosed with like stable or unstable
yeah.
angina, and this is like a normal thing for them. Um, I do think you have some autonomy, like in that stable, unstable, to make that determination on your own, regardless of what like the actual algorithm says. Um, the algorithm, I like to think of that as like it exists for when you're not sure what to do, right? It's there as like a fallback. Like if you're like what do I do? I can't figure out what's going on. Okay, my patient fits into this box, and here's the treatment. Um,
Mhm.
but there's always going to be like some gray areas there. So yeah, I'm with you on that one. That like if even if your patient has chest pain, but they look fine to you, they look stable. Um, I think that's totally reasonable.
Yeah, I would,
Yep.
I would be there. And okay, so I had a buddy of mine. He's been a medic since like 2008 or something. He's getting up there in age, and he was telling me at one of his other jobs he tubed a patient that still had like, he doesn't have RSI at this place. He said it was a stroke and respirations were terrible, super shallow, super low. And he said that he bagged the lady and then intubated her, and was saying that she had like a gag reflex, but it the way he made it sound was like she had a gag reflex, but it wasn't like intense enough to aspirate or any of that. Doesn't that seem, is that normal? Or because the only times I've ever intubated is codes, and like obviously that's pretty, it's like an
Yeah,
easy intubation.
so you can like depending on like how like if you tried to just intubate somebody with an intact gag reflex who's like at their baseline, you probably
Mm-hmm.
wouldn't be able to pass the tube because their gag reflex is going to be strong enough that you
Mm-hmm.
like it just won't work. Or but there is like it does exist on a scale. So like as a patient like goes from like normal human towards like being unconscious, like that reflex will deteriorate. It's not like an on and off switch.
Okay.
So yeah, you can see that where you have somebody who's like kind of like declining on that spectrum or like swirling the drain as everyone likes to say, where you could intubate them even though they have like a weak gag reflex and you can still intubate them. You see this more often in kids in particular with like babies like um, most everywhere now like in the pre-hospital realm is like moving towards like if the patient has a pulse we're giving drugs, like we're doing some kind of like pharmacology to mitigate pain and to sedate the patient before we pass a tube. But it's not uncommon to for like in a NICU or for like in a neonatal resuscitation for like babies to be intubated without any medications. And if they do have a gag reflex, it's just because it's not strong enough to like to stop the procedure. Um,
Mm-hmm.
but generally with adults, we don't see that too often. Um, I guess this makes me think of like when I was working on the trucks where I worked, we didn't have RSI either, and we would use we were allowed to nasally intubate, and I guess that was the same thing because you had patients who were like somewhere in the middle. They weren't like totally unresponsive. It wasn't like a crash airway, but they like had some, and yeah, you could just push past through it sometimes, and sometimes you couldn't. But um, yeah, so I guess the short answer would be like it all like lives on a spectrum. So
Yeah,
there is a case where you could intubate someone with an intact gag reflex just because it's not that strong.
I like it. Working on an ambulance made me realize how much they don't teach you in school, just because there's not enough time to.
Yeah, for sure. Yeah, I mean, I think that conversation comes up quite a lot, like in the EMS community, especially like folks doing education, like, oh, like I wish I would have known this in
Mhm.
EMT school or in medic school, but like realistically, you got like a lot of shit to learn already.
Yeah,
And like this kind of stuff, I don't know, like it's good to know, but I don't know how valuable it is to focus on during your initial training. Like the whole goal of a training program is to make you like a competent entry level provider, um, with the expectation that you're going to like keep on learning afterwards. Um, but yeah, I think this is an ongoing struggle for everyone who like manages an EMS training program. They're like, I want to teach all these things,
yeah.
but I've only got so many hours and so much time in the classroom.
Hmm.
And at a certain point, like if you got if you're you know pushing too much information on somebody, they're not going to retain it anyways.
And that's what I was going to say. Sometimes things can be very confusing if you don't know like the basics of it.
For sure. Yeah, I mean, like for example, I had been a medic for probably like 5 or 6 years before I finally had it committed to memory, like which vessels perfused which parts of the heart. Like when I was looking at an EKG, like I knew the side of the heart, right? Because we learned that in medic school, but it took a long time for me to like make the connection to like, oh, okay, like this piece of the heart is perfused by this vessel.
Yeah,
And that was me like every once in a blue moon, like hitting the books again. And like it took a long time before it finally clicked. So I think that happens a lot. Um, so yeah,
I
no,
like that very specific, like the left main coronary, left anterior descending. Like I like that because it's kind of like now why some heart attacks are more feared than others, like it
Right,
really,
for sure.
all the vessels absolutely massive. And it helped me a lot with like they always say if they have a right-sided heart attack, like stay away from nitro, but the right-sided and inferior basically all from the RCA, unless you're
Right.
like 10% where you're not. But
Yep.
I always like that, and it helped me understand um, EKGs a little more too. Now granted, have I been in a situation where I'm like, oh, thank God I knew what artery? No, but
Right.
I
It's
feel,
definitely a icing on the cake kind of thing.
yeah, exactly. Plus, it's just fun. It's just fun to know things about the body.
Yep. I'm with you on that.
So, well, that's all the real ones. I got one. So I'm starting up cardiology. I've got to tutor these kids, and this kind of goes with what we were just talking about, the not feeding them too much information. Do you think I should use it more as like a Q&A? Because they are already getting their like mm, like main learning done with their professor,
Right.
correct? So
And
by the
they,
time wouldn't you think that they would have questions of their own and know what they don't understand? Or
yeah, ideally. I think like when you first learn something though, it takes a while for you to like see whatever it is you're learning in practice and like to have questions. So
mm-hmm,
like they may not come to you with questions, like maybe have a couple of things that you can like review with them. One thing that
mm-hmm,
I think helps a lot is like drawing out things. So
mm-hmm,
like for me, what I'll do is like have people draw like just an EKG strip, like what does this hump look like? And then like what does the P wave actually look like in lead two? What does your QRS normally look like? Because a lot of times we just like draw a squiggly line, but you're like, wait a second, like in lead two, it actually goes this direction first. Like it
yes,
goes up first. If you see it go down, like this would be a problem. Like you can talk through those things and get them to like actually draw up the specific details. And then you can also like look at their their sizing. Like let's say they like drew like I'm gonna draw it across the screen here. Like they drew a hump and then they do their QRS and then like right after it they put a T wave and you're like, well, like normally like there's some space here, right? And normally like your P wave is like pretty close to your QRS. And you can just like reinforce that like the first step in all this is just like looking for what's normal. Yeah, it's like a good place to start. And then when you get to like more advanced things, like I like if we're talking about like drawing the vessels and like which vessel perfuses which part of the heart, like I normally would just like draw actual heart, like draw my heart as like a heart shape like you see on a Valentine's. And then from there, like just sketch out like the vessels, like you from just like right to the crease in the middle is where you have your um like your left main coming down and then it splits off to the left and then to your circumflex and then your right coronary artery goes around the back and you can kind of like just draw that in a simple sketch. And those are like just like simple activities to just reinforce those ideas. um,
okay,
like I wish I had like been more into like when I was in medical school and like for most of my like life learning in school, like I was always just like reading the books, just like read
mm-hmm.
things over and over. But I think that's like a pretty time intensive way to learn things. Like it works, right? Like I made it here. But I think there are better ways to get those concepts like drilled into your brain. I've come around to the idea that like making things like drawing pictures and like creating content, like putting things together, like really helps me. So I don't know if that's useful for you or not, but
Like, very useful because
yeah, just get a box of crayons. Yeah, and you'll
oh,
be fine.
I got the expo markers lined up and ready to go. They've got this big fancy like kind of like a study hall at the school, which is shocking because it's a community college and not a very good part of the city. But boy, did they pour money on it.
Yeah, that's awesome.
Besides
Sweet.
that, that's all I got for you. I try not to have anything because that was like crazy, and I try to keep everything at least somewhat pertainable to like my everyday job.
Yeah, no worries.
Um,
No, those are good questions. And there's also like, I mean, some of the stuff like I got your list the other day and I had to go through it like, I should probably know this off the top of my head, but let me like look into this a little bit. So, I mean, this is why we do it as well, right? It's not just us. spouting things we already know. It's also a learning opportunity for us.
Mm-hmm.
So,
I had that on the first one. The very first time that we met, you told me don't worry about the 1 milligram, the 1 to 2 milligrams of Versed for like your CPAP patients that are really fighting it.
mm-hmm.
I gave this guy one, and it chilled him. It kept him from being intubated. It was
Awesome,
badass.
man. Yeah,
Like,
that's sweet.
I kept looking up at him. I'm looking at the monitor.
And he didn't stop breathing on you, huh?
He did not stop breathing on me. It
Oh
was
yeah.
station. But I did have that one doctor tell me, well, she's a nurse prac, I come to find out. And she's the one that told me I'm going to knock out this patient's respiratory drive because I put him on CPAP. Not that guy, but somebody like,
Just in
it was,
general.
yeah, it was that day I texted you. And I'm over here like, oh, this is a great call, right? Had terrible vein, good IV, like had to use like baby IVs on him. It was just a great call. And we got like 40 minutes to work because we were coming from the sticks. And when she said it, I was like looking around, like nobody else hearing this shit right now.
That's awesome.
Doc, like kind of like the main doc of the hospital or the ER, and he was like, I didn't say a name, but he knew exactly who told me that. I didn't know that he does the scheduling, so he knows exactly who was there But he was like, yeah, he was like, you should just ignore that. He's like, don't let anybody accuse you of killing somebody. I was like, all right, sounds good.
Yeah, I mean, I think that's in general good advice. Like whenever you hear something like that, and like like I'm not sure if that's true. Like always get a second opinion. Yeah, I mean, in EMS, we're prone to making like statements of authority based on like cases of one.
Yeah.
So just yeah, it's a good thing to keep in mind.
Yeah, she's nice. I mean, she's a nice person. Don't get me wrong, but boy, not a good way to start out. That was like the second or third time I ever met her too. I kind of hated her for like a month, but then I was like, yes.
Yeah, you got to get past that.
Well, dude, if you're good, I'm good, man.
Sweet, man. Well, yeah, that was good stuff. And
I'll text you my email. Would you mind sending me those? Actually, you have my email. Will you send those articles
yeah,
over?
for sure. Yeah, and I think eventually I'll put this together into like a video, like put it up on the YouTube channel, and I'll put links in that video as well, so other folks can nerd out with us. I think that'd be rad.
Yeah, man, you're gonna be famous one day.
I doubt that. Right on,
Give
dude.
me.
Well, take care, and yeah, let me know next time you get a page of notes, a page of questions, and we'll do it again.
Sounds good, man. If you're okay with it, some like a month-ish from now.
Yeah, for sure. Anytime, dude.
Sweet. Thank you, man.
Yeah, take care.